Hi students. First, I want to acknowledge that this is a really hard topic that we'll be discussing today. It can be really difficult for people because of your concerns of some risks that you yourself might be facing, some risks that might be faced by family members or loved ones, or some difficult decisions that some of your loved ones may need to make if they are healthcare providers. But I also think it's an incredibly important and germane topic for us to be talking about in our current crisis and in the context of how decisions get made in global health. So for class today, I assigned an article that just came out a few days ago in the New England Journal of Medicine on the fair allocation of scarce medical resources in a time of COVID-19. This is one of the most respected journals in medicine, and the 10 authors of the article represent departments and programs of medical ethics, public health, law, and emergency medicine at 7 leading universities across 4 countries and 3 continents. I bring this information up not to argue from authority. In fact, in a talk from Ben Goldacre that I've also assigned for class today, he addresses why arguments from authority are considered weak evidence in science. Rather, I bring this up to highlight that in a critically important and swiftly changing crisis, highly qualified scholars and clinicians have come together to apply foundational principles of bioethics to chart a framework for making heartbreaking decisions in the fairest way possible. The authors of the article that you've read for class today use sound, quantitative evidence to estimate the U.S. health system capacity in terms of ICU beds, ventilators, and healthy respiratory therapists and critical care staff as the pandemic continues. They then address 4 fundamental values that have been used in previous proposals for allocation of resources in pandemics and other times of extreme scarcity. To maximize the benefits produced by scarce resources, to treat people equally, to promote and reward instrumental value, and to give priority to the worst off. In their article, they also emphasize that a person's wealth should not determine who lives and who dies. The application of these principles to the current crisis led the authors to 6 specific recommendations. First, to maximize benefits in terms of both saving the most lives and maximizing improvements in an individual's post-treatment length of life. This means that those who are sick but who could recover given treatment should be given priority over those who are unlikely to recover even if treated, and those likely to recover without treatment. The authors take the position that removing a patient from a ventilator or an ICU bed in order to provide that resource to another patient in need is justifiable, needs to be made known as a possibility to patients and their families at admission, and is likely to be extremely psychologically traumatic for clinicians to do. Second, that critical COVID-19 interventions such as testing, PPE, and treatments should go first to frontline healthcare workers and others who care for ill patients, and to those who keep critical infrastructure running, particularly to workers who face a high risk of infection and whose training makes them difficult to replace, because these workers are essential to pandemic response. 3, that patients with similar prognoses should have treatment allocated according to a foundational principle of equality, such as by using a lottery or random allocation, rather than following a first-come, first-served model. 4th, that these guidelines of how to prioritize care should differ by intervention and respond to changing scientific evidence, with a consistent aim to maximize benefits. 5th, that research participants should receive some priority for COVID-19 interventions, but only as a tiebreaker among patients with similar prognoses. And 6th, that there should be no difference in allocating scarce resources between patients with COVID-19 and those with other medical conditions that require prompt medical attention, and that the value of maximizing benefits applies across all patients who need resources. Again, this is a hard topic, and these are hard decisions. These recommendations were offered in the hope of developing guidelines that can be applied fairly and consistently across cases, rather than leaving individual clinicians to decide without guidance which patients receive life-saving care and which do not. Everything that we can do as members of society to decrease the risk that we or someone we might transmit the disease to will need life-saving interventions, the better off we all will be. And that's why we're being asked to do our part in staying home to flatten the curve.